So this brings us to a really good tumor board discussion. I talked about what my feelings are on maintenance. I tend to offer it to most patients. I think this ideal of how long and when is a really good clinical question and clinical trial question. I wanted to talk, Pei, maybe we can start with you, about this patient's cytogenetic risk status and how you would assess that, or did they meet criteria, and if you think that impacts this case, and the role of MRD testing and what kind, FISH, NGS, or flow.
Sure. So this particular patient has a translocation involving 414, which involving the genes of FGFR3 and immunoglobulin, and this is known to be an adverse prognostic factor. And it used to be considered high risk, and because of the bortezomib, there's literature saying that this could be intermediate, but regardless, it's considered to be adverse prognostic factor. As far as the MRD testing, definitely the flow cytometry is very important. Both flow cytometry and next generation sequencing are very useful, and many studies have demonstrated the utility of MRD testing in prognostication and also risk stratification. In our institution, we do both the flow cytometry, and also we send out the NGS studies for the MRDs. For our flow, we use the test that it has been validated against the Euroflow standard, which has the sensitivity of up to 10 to the fourth. And the flow has the advantage of being fast. It can be, the turnaround time is about 24 to 48 hours. However, it does require the fresh tissue, so that's the disadvantage. NGS is 1 log more sensitive. It does not require the fresh tissue, so both have pro and cons. So clearly this patient, MRD testing is indicated.
Great. I think that's really important. This issue of MRD it's like the star issue sometimes, because it's becoming such a great, useful tool for prognostication. I know, Ola, you're very interested in making this something that the FDA looks at as well. I wanted to get you guys' opinion, Ola and Ajai, about the prognosis for this patient. It's kind of a lot to unpack in this case, because they had transplant, they did well, but they also have this technically adverse risk factor with the translocation. So what do you think about the prognosis for this patient?
Well, I think when we talk about prognosis, we have to keep in mind that these models that were developed, they were developed in the light of given therapies. Many of the studies that are kind of underlying of these current models we have, they are therapies that we don't necessarily use today. In my hands, I think that the number of patients that truly have an adverse prognosis is a shrinking species if you give the best therapies we have. I think if I think like 5 years back or so, maybe a quarter of the patients I saw, I felt clinically had an adverse outcome. I think maybe more 15% or so of patients I treat today have an adverse outcome. And I think that's a reflection of the better drugs we have. The reason I bring it up is because I think telling a patient you have adverse outcome is something that the patient will have to live with for the rest of their life. So telling someone you have bad outcome, if they live for a very long time, that still is something that's going to overshadow the patient. So these are personal kind of reflections on that topic. On the other hand, you don't want to not tell patients about what's known. So usually the way I address that, I say that based on the literature, your workup indicates that you have this feature. So this is what it is. The good thing is that you have had a good response. And there is also emerging data showing that if you reach MRD negativity, that seems to be the strongest prognostic factor. Right. And if you can maintain your MRD negativity, even if you have this 414 translocation, there is now pretty strong data from multiple studies showing that seems to kind of wash out the adverse impact of a 414 translocation. So again, these are kind of personal reflections. That's how I usually deal with that in my clinic.
I would echo your comment that I think risk really needs to be thought of in the context of therapy, both for ISS as well as FISH and molecular data. But I think one of the challenges, and my pet peeve, is when there's a study that's a phase 2 study that's saying that a particular molecular risk is being overcome. You can't do that, because I think to show, first of all, when we're talking about risk, we should not be talking about response rates. We should be talking about survival-based endpoints, because high-risk patients can respond well. It's the durability response that's limited, and whether that translates into an OS. So with that said, so if we agree we don't look at response rate and we look at PFS and OS, we really should be looking at these Kaplan-Meier curves, but not just high risk and standard risk, but we really should have conventional therapy and novel therapy. So really, every risk-based study discussion should have 4 curves. Standard risk, standard therapy, standard risk, novel therapy, high risk, standard therapy, high risk, novel therapy.
And maybe in addition, who got MRD negativity and who didn't in that?
Well, so I think even before we get to MRD, because that's even more complicated, but you need to see all 4 of these curves. And because if you're really saying that something is high risk, you should be, you want to know, is novel therapy improving or overcoming that risk? And what's interesting about 414, as Pei alluded to, unlike some other high risk, proteasome inhibitors seem to be bringing the 414 curve right up next to the standard risk patients, which suggests that not only are we improving, but maybe we're overcoming 414, which is why it's been moved out in some classifications from high to intermediate risk. However, to your point, I think MRD is really important. However, what we also don't talk about is 2 things. One is we have to think about the patient's osseous disease. So what if you're MRD negative if you have osseous disease that's still FDG avid? Right. So we need to integrate the rest of the patient's data along with MRD. And the second time point, particularly for high-risk patients, because I believe 15 out of the 16 studies that have been done with high-risk patients in MRD all show that MRD negative patients, high-risk patients who are MRD negative still perform worse than patients who are high risk, standard risk and MRD negative. So MRD means different things in high risk and standard risk. And to that point, I think if you're going to talk about MRD negativity at high risk, it shouldn't just be at one time point, but at a second time point. It's a sustained MRD negativity. So I think there's a lot of subtlety that needs to be talked about more clearly when we talk about risk and MRD, particularly in this kind of a patient who has a lot of treatment options.